The Joker, demystifying the story of manual versus femto CCC. This story has 6 interesting parts: placement, size, shape, creation, centration, and strength. For perfect manual CCC, imprint on the corneal epithelium with the rhexis marker on the visual axis for accurate placement, and enhance this imprint with a drop of dye of methylene blue for a perfect guideline for a manual CCC. In femto CCC, the laser ensures automatic scanning, detection and placement for a perfect CCC in the center of the bag. Ideal size of a CCC is perfect optic cover. In manual CCC, one has to follow the rhexis marking made on the cornea or the image-guided technology for perfect sizing. Femto CCC is customizable as to the size of the optic. Shape of the manual CCC is guided by chamber dynamics and shearing forces, and therefore consistent shape is always a challenge. It can be oval, pear-shaped, orange-shaped, or even heart-shaped. The femto CCC is always perfectly circular. Once marked with a rhexis marker, it's important to fill the anterior chamber adequately with viscoelastic till the pupil slightly dilates. Then follow the mark or the image-guided technology to make a perfectly circular round rhexis. But at times it tries to run away in different directions. In such scenarios, one can really rescue it with a microforceps. At times the anterior zonules are weak, so there is no counter traction. Here a dispersive viscoelastic will help you get a perfectly round CCC. In special situations like a manual CCC in hypermature cataract, use of a microrhexis forceps to nick the anterior capsule and release the intralenticular pressure. Aspirate the same and inject a dispersive viscoelastic to flatten the anterior capsule and create a rhexis. Another approach to create a spiral CCC in hypermature cataract to prevent an Argentinian flag sign. In creation of a femto CCC in hypermature cataract, an additional step of staining the anterior capsule with a dye to make sure that the CCC flap is freely floating is quite essential. The creation of the femto CCC in subluxated cataract is beneficial. One can move the CCC away from the area of subluxation. The CCC then is easily pinched out. Yet another case of subluxated cataract and the creation of the rhexis. In this case, we create a smaller rhexis which is away from the area of subluxation. After the cataract extraction, we place the IOL in the bag, which actually centers in the center of the bag, irrespective of where the CCC is really made. Yet another case of a femto CCC in a subluxated cataract. Look at the ease of removal of the rhexis, inject the viscoelastic, and we create the space for the endocapsular ring. Femto has definite advantages in difficult cases like 16-cut RK operated patient. Look at the ease of the removal of the CCC. Further applications of the femto include a case of microspherophakia, a very shallow anterior chamber. One can actually adjust the CCC in the center of the bag and the case can be approached very safely. Another tough case of a posterior polar cataract where there is a pre-existing breach in the posterior capsule. A perfectly rounded CCC is helpful in such cases. In this case, the IOL could be placed safely in the bag.
Nice shot!
In manual CCC, a perfectly centered rhexis on the bag is ensured by marking the visual axis and following it to create the CCC. In femto, all of this is automated in creation of perfectly round circular CCC. now we arrive at the most interesting topic of comparison of the strength between manual and femto CCC. We do know that manual CCC is strong enough to hold on to capsular hooks, but manual CCC can also tear and give way in a simple step of hydro. In this particular case, an MVR nicks the anterior capsule, and that particular breach is included in the boundary of the creation of the manual CCC. This is actually a weak spot. During irrigation aspiration, this is the same spot which is a weak spot. The CCC tears and it gives way. If the femto CCC is free floating, the CCC is strong enough to hold on to capsular hooks or iris hooks. But if this femto created CCC is found to have capsular tags, they act as points of weakness, and during irrigation and aspiration, this spot gives way, causing an unexpected capsular tear. Let us see yet another case of a femtorhexis having a capsular tag and the same spot giving way during irrigation aspiration. So if the femto CCC is not freely floating, it can lead to capsular tears. Adequate placement, sizing and shape in manual rhexis can be achieved by marking the corneal reflex or by following the superimposed image-guided technology. In femto-assisted rhexis, all of this is automated. The benefits of femtorhexis are seen in special scenarios like a hypermature cataract, microspherophakia, microophthalmos, and posterior polar cataract. Subluxated cataracts, where we can actually move the rhexis away from the area of subluxation. While performing femtorhexis in subluxated cataract, we can decenter the rhexis away from the area of subluxation. Having said that, we know that IOL always centers in the center of the bag, and the decentered rhexis can later on be enlarged to get a perfect wraparound on the IOL. The main controversy between manual rhexis and femtorhexis is strength, but we know that manual rhexis stays intact with capsular hooks holding on, but it can give way in a simple step of hydro. Femto CCC is as strong as manual CCC. It can hold on to capsular hooks as well as iris hooks, but sometimes there are capsular tags left which are weak spots which can give way, leading to capsular tears. Another benefit of the femto CCC is an accurate IOL centration, a less incidence of IOL tilt and decentration.